Thank you very much for this opportunity. And after an elaborate discussion on the 5-year update of the Crown trial by Dr. Sudeep, now it's time to reflect upon the adverse effects that happened that were the main concern always with Lorlatinib. And so I will be talking about this 5-year follow-up, the kinetics and the management of adverse events associated with Lorlatinib. So Dr. Sudeep has already set the stage for this. No need to repeat. It is a practice-changing trial. Median follow-up of 5 years is there, and PFS in the Lorlatinib arm has not been reached because it is such an effective drug that we don't have a PFS even at 5 years. But it has a unique safety profile, and this post-hoc analysis was done. So 5 safety key takeaways that 50% of the patients were still on Lorlatinib in first line at 5 years. No new safety signals had emerged, and treatment discontinuation remains low. Permanent discontinuation overall just touched the double figures, only 11%, whereas only 5% were related to Lorlatinib. Dose reduction was seen in 49 out of 149, that is roughly you can say 33%, one-third of the patients, and median time to first dose reduction was 21.6 weeks. And it never affected the efficacy as very nicely depicted by Dr. Sudeep. So time to onset and duration of adverse effects. First of all, coming on to the hyperlipidemias, mainly hypertriglyceridemia and hypercholesterolemia, both of them are the most common ones. And any grade adverse effect dyslipidemia starts within 15 days. And when we look at the grade 3 dyslipidemia, it comes at 6 months. And median duration was also 37 months. When we come on to any grade edema, peripheral neuropathy, and CNS effects, then median time to onset was 2 to 4 months, and median duration was 8 to 18 months. Only weight gain was the adverse effect that had a prolonged duration that stayed for that was more than equal to grade 3, and that stayed for more than 3 months. So coming on to the hyperlipidemia, again, we are addressing hypercholesteremia, which is seen in around 72% of the patients, and hypertriglyceridemia, which was there in around 69% of the patients. And so it was there in majority of the patients. 90% were managed with either co-medications, that in 71% of the patients, or when we combined with observation only, overall there was 90% of the patients that could be easily managed. Only remaining 10% required drug interruption reduction, and less than 1% required drug discontinuation. We manage them with those statins that have less interaction with CYP3CA, because then the Lorlatinib levels are not much affected. And we have easily available rosuvastatin, which we can always use in the setting when we are using Lorlatinib to control dyslipidemias. However, important thing with the treatment with Lorlatinib is the many side effects still were unresolved, like hyperlipidemia. In 45% of the patients, still the hyperlipidemic events were not resolved. But there was only one and only event when it required a permanent discontinuation. Coming on to the CNS adverse effects, again, most of them were grade 1 of grade 2 severity. Only 42% of the patients had so. And out of these 42%, 86% was grade 1 and grade 2. And they occur in the order of cognitive effects, followed by mood effects, followed by speech effects, followed by psychotic effects in incidence. Prior brain radiotherapy had an effect on the CNS effects, and there were 9 patients who had received prior brain RT, and around 6 out of these 9 patients had CNS effects. When no prior RT was given, the incidence of CNS effects reduced to 41%. That was seen in 140 patients. So coming on to the incidence and the prevalence of the CNS adverse effects, it did not increase over the period of time. Rather, when you see the dark blue bars, that is the incidence. So incidence was initially higher only in the first year, and eventually it dropped down nicely. And by the end of 5 year, probably the incidence was quite low. Whereas the prevalence tend to remain stable, and it never increased over a period of time when we look at the CNS effects. And these CNS effects, they occurred in the incidence of most common was the cognitive effect, followed by mood effect, followed by speech disorders, and followed by psychotic effects. Then total CNS events were 118, and more than half, that is 58%, there no medical intervention was required. Out of these 58%, 33% completely resolved, 24% were partially resolved, and there was only 1% that did not resolve. There were 14% that required co-medications without any interruption, and out of these 14%, 8% had completely resolved. There were 14% who required dose interruption alone, and again 12% were completely resolved. So once we interrupt the dose, the chances that it will be completely resolved increases significantly. And then there was 6% who had dose reduction alone, and out of these 4% CNS effects were completely resolved. So overall, 60% of the CNS adverse effects resolved with management strategies only, either with co-medications or with dose interruption. When we come on to the weight gain, around 44% of the patients, the weight gain was seen, but the significant, that is grade 3-4 weight gain was seen in 23% of the patients. And baseline weight did not have any influence on the subsequent weight gain. That is whether the patient was overweight or underweight. It did not lead to the baseline weight basically did not have the future weight gain chances. And also, it is important to note that the weight gain and peripheral edema, it seemed to correlate only in a fraction of patients, that only in 40% of the patients there was overlap. So probably there is a different mechanism whether there was a weight gain, whether for the weight gain and for the peripheral edema. The peripheral edema was not actually the cause of weight gain in all the patients. And most of the weight gain, around 95% of the weight gain, did not require any medical intervention. It was primarily managed with the lifestyle modifications. 35% resolved with no medical intervention, and 11% was partially resolved, 49% unresolved, but it did not affect their quality of life or the drug administration. And there was 2% each for dose reduction, dose interruption, and dose reduction plus dose interruption. So overall, it stayed there, this side effect, but it was not a very worrisome side effect that interfered with the treatment. So to conclude, I would say that this was a much needed post hoc analysis, because adverse events was always a concern when we were using Lorlatinib initially, when Lorlatinib was launched, and we were comfortable using alectinib. But I think this post hoc analysis really clears a lot given the efficacy outcomes with Lorlatinib. Most adverse events, they occur within 4 months of starting treatment, and more than equal to grade 3 events occurred even within 9 months. And very few patients required permanent discontinuation. Major side effects like hyperlipidemia, easily manageable with the drugs. Again, the incidence and prevalence of CNS effects, again, it was did not increase over a period of time. It was not a concern over a period of time. It remained stable. Only initial year showed the significant CNS effect. Weight gain, again, it was managed with lifestyle modification. So overall, I think adverse effects now, we are more comfortable dealing with them, especially when we are using such an efficacious drug Lorlatinib, especially even if the brain metastasis is there, because as Dr. Sudeep has shown excellent efficacy and outcomes. Thank you.